Hello everyone, this is Dr. Sendil Kumar from Gateway Clinics, Coimbatore, India. I am going to talk about inguinal hernia surgery by laparoscopic approach. This presentation we are making for the younger surgeons who have started laparoscopic hernia surgery to familiarize with the tips and tricks of laparoscopic hernia repair. As you know that we have got three approaches to repair a hernia, inguinal hernia. One is TAPP approach, that is transabdominal preperitoneal approach. The second approach is STEP approach, that is totally extraperitoneal repair. And recently introduced ETEP approach is also used to treat inguinal hernias. What is the goal of any hernia repair? Patient should get an effective repair with minimal operative as well as post-operative discomfort, with lowest possible recurrence rate, rapid return to normal activities, and it should be cost effective. It should be reproducible among hernia specialists and general surgeons. And this image you can see, it is a well dissected operative field where mesh has been placed and we are fixing the mesh to the Cooper's ligament. What is the definition of transabdominal preperitoneal approach for inguinal hernia repair? It is a laparoscopic surgery wherein the surgeon enters the peritoneal cavity, incises the peritoneum and enters into the preperitoneal space, places the mesh covering the hernial defect, and the peritoneum is finally closed by using either sutures or tackers. Now let's do it step by step. The first step is entering the peritoneal cavity, and the second step is incision of the peritoneum to create a peritoneal flap. And during the dissection we have to identify the anatomical landmarks, and as you proceed with the dissection of the peritoneal flap, you will be identifying and reducing the sac, and after that we have to deploy and anchor the mesh, and we have to close the peritoneal flap, and finally without forgetting take out all the needles and sutures, and we have to close the port which is 10 mm or more in size. Regarding preoperative care, it is recommended that the patient empty his or her urinary bladder before the operation, and restriction of per and postoperative intravenous fluid administration reduces the risk of postoperative urinary incontinence. If you expect technical difficulties, example after prostatic surgery, large scrotal hernia, or an extended operating time, like if you are dealing with a recurrence following previous TAPP repair, you have to catheterize before starting the procedure. That is very important. And regarding the preoperative care, another point is antibiotic prophylaxis. Antibiotic prophylaxis in inguinal hernia surgery is controversial. The overall infection rate is low with a mean value of 1 to 4%. Antibiotic prophylaxis may reduce wound infection rates with an impact on patient satisfaction, wound care and sick leave, but it also has got risk of toxic allergic side effects, bacterial resistance, and it also involves higher costs. There also has been discussion on the risk factors used to select the best candidates for antibiotic prophylaxis. If the patient's age is more than 75 years, obese patients, and if you are planning for urinary catheterization, it is better to administer antibiotics to reduce the chances of infection related complications. What is the patient position? Patient is normally placed in supine position, and a patient should be strapped adequately so that while giving steep Trendelenburg position, the patient will not move from the table, so you can avoid risks of falling. And sometimes we will ask for more head down position like 30 degree or more than 30 degree. Then if the patient is not adequately strapped, then the risk will be more. So head down position during the operation and slightly approximately 15 degree turn towards the surgeon is very useful. It will reduce your shoulder strain, it will reduce the strain to your left shoulder. The operating surgeon and the camera assistant, we usually stand on the head end of the patient, and the monitor is placed on the foot end of the patient. So patient is in supine position, surgeon and assistant is standing on the head end of the patients towards right and left shoulder respectively. Monitor is placed towards the foot end, and the nursing staff will be staying on the right side of the patient. The first step is entering the intra-abdominal cavity. The trocar placement, establishing carbon dioxide pneumoperitoneum using venous needle. We always follow the technique of venous needle insufflation, and the 10 mm camera trocar is placed well above the umbilicus, at least 4 to 5 cm above the umbilicus. It is in the midline, and under laparoscopic view, 2 5 mm ports are inserted in the mid clavicular line, about 2 cm below the level of the horizontal line from the optical trocar. So one camera and 2 working ports on either side. This is the port position. You can appreciate the camera trocar is placed well above the umbilicus, and 2 working ports 5 mm on either side. So one 10 mm and 2 5 mm trocars. The intra-abdominal cavity is thoroughly visualized with the telescope, and intra-abdominal findings are reported. Like intra-abdominal pathology and inguinal hernia defects and sacs. If there is an asymptomatic sac identified on the opposite side, contralateral side, our protocol mandates its repair, even though at this time we are unsure of the exact clinical significance. So if there is any additional hernia, if you are going for a right inguinal hernia surgery, after putting your telescope, if you notice left inguinal hernia, it should be repaired during the same time. The second step is creation of the peritoneal flap. For that, you have to make an incision to the peritoneum. Usually the peritoneal incision starts about 3 to 4 cm cranial to the anterior superior iliac spine. Or if you see a defect, you can make an incision about at least 4 to 5 cm cranial to the upper border of the hernial defect. So if you are placing an incision, peritoneal incision well above the hernia defect, there is no need to create upper flap. Usually the creation of lower flap alone is adequate. And the aim of this pre-peritoneal dissection step is to ensure best possible positioning of the mesh. In this way, several anatomical landmarks needs to be identified, as well as dissection of the hernia sac should be completed. The following anatomical landmarks are identified in any laparoscopic inguinal hernia surgery. One is inferior epigastric vessels, urinary bladder, pubic bone, Cooper's ligament, lacunar ligament, external iliac vessels, corona mortis, vast difference in male and round ligament in female, gonadal vessels, deep ring or internal inguinal ring, and iliopubic tract. In this image, you can appreciate nicely the horizontal structure which is called iliopubic tract. If you give a nice traction with your left hand, this plane will open up. So use your left hand effectively for dissection of the hernia. So you give a nice pull to the peritoneal flap so that all the areolar tissue will be exposed nicely. Then you can use minimal electrocautery to create a flap without any bleeding. In this small video, you can appreciate here, this is the right inguinal hernia. We are entering into the hernial sac, and we could see a congenital type of sac, and we are starting the incision. Incision should not be started at the level of inferior epigastric vessels to avoid injury, and give a nice pull, make a small nick. The carbon dioxide will enter into the preperitoneal space, and carbon dioxide itself will dissect the preperitoneal space, and give a nice pull to the peritoneum, so that you can have an incision which actually stops at the level of medial umbilical ligament, so that if you cross the medial umbilical ligament, there is more chance of bleeding, and if the incision is placed at lower level, there is more chances of injuring the perivesical blood vessels as well as the bladder. So you have to stop your incision medially at the level of medial umbilical ligament, and laterally it can go up to it should be curved like so. Start medially it is horizontal, and laterally it is slightly curved. That is the type of incision normally we use for TAPP repair. And raising the peritoneal flap, you can appreciate we are giving a nice pull with the left hand and the planes are opening up, and by using a monopolar scissor is the only instrument used in most of the hernia surgeries for the dissection. You give a nice traction and the planes will be opened up nicely, and you can explore the area to expand the operative field. This is the proper plane, so don't deviate from this plane, stay in this same plane until the end of the procedure. So bleeding happens only when you cross over from one plane to other plane. So after creating the medial dissection, we are coming to the lateral side. We are entering into the lateral inguinal space, and for that we have to release the attachment of fascia transversalis. So first dissect the medial side and then dissect the lateral side, then you have to come back to the sac proper. This is an important landmark in any hernia surgery, otherwise called lighthouse sign. It is nothing but Cooper's ligament, pubic arch, the shining periosteum that will give, especially for TAPP repair. This is an important landmark which is at the midline, which needs to be exposed during the initial part of your dissection. So that will help you to orient yourself to proceed in which direction you have to go. And any hernia surgery, you have to cross the midline. If you are dealing with right inguinal hernia, you have to cross to the left side. If you are dealing with left inguinal hernia, you have to cross to the right side, so that the mesh will cross the midline. And you can see in this dissection, you can appreciate the Cooper's ligament, the peritoneum, which is entering into the deep inguinal ring as indirect inguinal hernial sac. So this is the way we have to do the dissection. And after doing your dissection in the midline, if you want to go beyond the inferior epigastric vessels to the lateral side, you have to release this fascia transversalis attachment to enter into the lateral inguinal space. The third step is identifying the anatomical landmarks. In 1956, Henry Fluchart came with the theory that all groin, inguinal as well as femoral hernia originate in a single weak area called myopectineal orifice. The boundaries are superiorly internal oblique and transversus abdominis, inferiorly superior pubic ramus, medially by rectus muscle, and laterally by iliopsoas muscle. So if you are able to do a repair which completely covers the myopectineal orifice of Fluchart, that means that you are doing an effective hernia repair. The advantage of this repair is it covers the femoral defect also. In open surgery, the mesh what we are keeping is covering the direct and indirect defect. In laparoscopic surgery, the entire myopectineal orifice of Fluchart is covered, so that the chances of getting femoral hernia in future, especially in a female patient, is reduced. And another structure, the iliopubic tract, which is a thickened lateral extension from the transversalis fascia that runs from the superior pubic ramus to the iliopectineal orifice as well as anterior superior iliac spine. That also needs to be identified, because the main importance of this structure is below the iliopubic tract you have got all the nerves. So whenever you are doing dissection, you should avoid using undue electrocautery, as well as you should also avoid actually using tackers or sutures below the iliopubic tract. That is very important. In this operative field, you can appreciate the boundaries of myopectineal orifice of Fluchart. One is conjoined muscles, the second one is superior pubic ramus, the third is rectus muscle, and the fourth is iliopsoas muscle. The main point which you have to notice here is the iliopsoas muscle should not be exposed. You should leave the fascia covering the iliopsoas muscle intact, so that the nerves will not be exposed directly to the mesh. If you are opening this fascia, if you are opening and exposing the muscles, then the chances of patient getting chronic pain in the groin after surgery is always there, due to mesh directly sitting over the nerves. So always preserve the fascia overlaying the iliopsoas muscle. The aim of laparoscopic exploration is to identify the anatomical landmarks, site of hernia, type of hernia. In this way, the Trendelenburg tilt needs to be increased to 30 degree to 45 degrees. The two triangles are vascular triangle, triangle of doom, and triangle of pain, which needs to be identified, and we have to identify the corona mortis also, because there is a risk of bleeding if you are not very careful when operating in this area. The triangle of doom landmark does protect the surgeon from damaging the external iliac vessels. A portion of these vessels may lie outside the triangle, especially in elderly individuals, due to the tortuous course of the external iliac vessels. And you can appreciate the beautiful triangle of doom in this picture. You can appreciate that medial border is formed by the vas deferens, and laterally it is formed by the gonadal vessels, and the third boundary will be the reflector peritoneum. The apex is at the level of the deep inguinal ring. The triangle of pain is another triangle. It is an inverted V-shaped area with the apex at the internal ring or deep ring. It is bound anteriorly by the iliopubic tract or inguinal ligament, and the other boundary is formed by the spermatic vessels. The following three nerves are at risk for injury at laparoscopic hernia repair. One is lateral femoral cutaneous nerve, femoral branch of genitofemoral nerve, intermediate cutaneous branch of the anterior branch of femoral nerve. So these are all the nerves. We have to be very careful to protect it from any injury during the dissection. The next three nerves are usually not in danger at laparoscopic hernia repair, but could be injured if excessive pressure is applied during mesh fixation, compressing the muscle enough to permit the staples to reach these nerves. It is interesting to notice that conversely, the below three nerves are in most risk in open hernia repairs, that is ilioinguinal nerve, iliohypogastric nerve, genital branch of genitofemoral nerve. In this triangle of pain, don't place staples or sutures to anchor the mesh, as several nerves which usually cannot be seen as they run just deep to the endo-abdominopelvic fascia. These nerves can suffer damage with electrocautery also, so you have to use very minimum cautery if at all used, and it can also be damaged by entrapment, which can cause pain. So this is this area. So if you injure nerves in this area, patient can come with post-operative pain. And as I told, don't open the endo-abdominopelvic fascia to expose these nerves to reduce the chance of patient getting from the post-operative pain. You can appreciate the anatomy. You can also appreciate the neural structures which is running in this triangle. So you can appreciate the lateral border of the reflector peritoneal, lateral femoral cutaneous nerve, anterior femoral cutaneous nerve or its other variable branches, femoral branch of genitofemoral nerve, femoral nerve from lateral to medial aspect. So this is a triangle of nerve. You can appreciate very nicely in this dissected image. You can see the iliopubic tract which is running horizontally, and you can also appreciate the gonadal vessels which forms the posteromedial boundary of this triangle, and you can also notice the fascia covering these nerves are preserved so that the nerves are not exposed to the mesh. Don't try to open this fascia to see the nerves. Corona mortis. It is a Latin word. Corona means crown. Mortis means death. So the crown or circle of death, that is the literal meaning of this word. The corona mortis refers to an anatomical variation. There will be an anastomosis, vascular anastomosis between the inferior epigastric vessel or external iliac vessels from above to the obturator vessels. So this actually runs over the Cooper's ligament. This anatomical variation, this vascular communication runs over the Cooper's ligament and posterior to the lacunar ligament. So with the carbon dioxide CO2 pressure of 14 millimeter of mercury, sometimes these veins will be collapsed. Unless you identify the vein and carefully avoid it during fixation of the mesh, there is high possibility of getting bleeding in the operative field. If you miss your plane, there is always a chance of injuring these vessels, very high chance of injuring the vessels. Iliac vessels, you will be very careful during your dissection, but in this area where the corona mortis is situated, unless you take extra precaution, there is a chance that you might injure the vessels, these vessels, and you can encounter a profuse bleeding which will spoil the entire field. So you have to be very careful while doing the dissection at the area of corona of mortis. You can appreciate in this picture there is a communication between the external iliac vein above to the obturator foramen. This vessel runs from the external iliac vein or from the inferior epigastric vessel to the obturator vessel. So this actually you can see it runs over the Cooper's ligament and it is running posterior to the lacunar ligament. So you can appreciate the anatomical structures in this area. And this is another view of bilateral corona mortis. You can appreciate both sides there is a communication. It is not very uncommon, it is relatively common. There will be a communication between the external iliac or inferior epigastric vessel to the obturator vessel. And this is another view where you can appreciate with the carbon dioxide pressure of 12 to 14 millimeter of mercury, the vein is collapsed and you can hardly see any blood in the collapsed vessel. In some cases, the corona mortis is the actual obturator artery arising from the inferior epigastric artery or from the external iliac artery. In this case, it is otherwise called aberrant obturator artery. The main source of obturator vessel origin is external iliac or inferior epigastric instead of internal iliac. Normally, obturator artery is a branch of internal iliac artery, but in this aberrant obturator vessel, the obturator vessel actually originates from the inferior epigastric or the external iliac vessel. And the other step is dissection of the hernial sac. The indirect inguinal hernia sac should be dissected very carefully from the spermatic cord. That is the main difference between the direct and indirect hernia is, in indirect hernia you have to separate the hernial sac from the spermatic cord. In direct hernia, you can just reduce, there is no spermatic cord relationship. It is essential to expose and know at all times where the spermatic cord is located. Direct hernia can easily be reduced. Particular care should be taken not to dissect lateral and inferior to the Cooper's ligament, because at this level you will encounter iliac artery and vein. So you should at any cost avoid injuring these major vessels. If you are not very careful, there will be a catastrophe, and take extreme care during the dissection at this area. And you can appreciate the dissection of indirect inguinal hernial sac. You can appreciate the peritoneum is followed, and if you follow the peritoneum, it forms a sac and which enters into the deep ring. This is indirect inguinal hernial sac. The hernial sac dissection is performed using traction and counter traction technique and with fine coagulation to coagulate smaller vessels. To avoid injury to the vas deferens and spermatic vessels, the sac dissection starts anteriorly. Always it starts anteriorly, because anteriorly there is no spermatic vessel or vas deferens. If you go posterior-medially, then you should be very careful. You will have the gonadal vessels laterally and the vas deferens medially. So that is an important point which you should remember. So you can open the hernial sac anteriorly without any fear, because there is no structure running over the anterior aspect. But as you dissect behind, then you have to be very careful. You can appreciate in this image that we are dealing a direct sac. The reduction of a direct sac is very easy, and you should identify a plane between the pseudosac, which is formed by the fascia transversalis and the peritoneum along with preperitoneal fat. If you apply gentle push to the pseudosac, it will move away from the sac, and it can easily be reduced. The direct sac reduction is very easy, and there is not much of a dissection needed for that. A large indirect sac may be ligated proximally. There is no need to go up to the scrotum to dissect the entire sac. If it is a large complete sac, you can divide the sac proximally and ligate it. Don't ligate the distal sac, ligate only the proximal sac, and without any risk of higher postoperative pain or recurrence rate, we can do that, but with an increased postoperative seroma rate. So that is the main point which we have to remember. And if you start dissecting the entire sac, there is a chance that you might be injuring the spermatic cord structures, so it's better to be avoided. So you can dissect up to the superficial inguinal ring, and you can actually transect the sac, ligate the proximal sac, and leave the distal sac. After completely coagulating the distal sac, you can leave it into the scrotum. When performing inguinal hernia repair in a female, extra effort should be undertaken to reveal and treat occult synchronous femoral hernia. In this case, you can appreciate this patient has got a femoral hernia also that needs to be treated, especially in elderly patients and female patients. So the femoral hernia is very common in female and elderly patients. This dissection you can appreciate with this small video. You can see the indirect sac, you can appreciate the iliopubic tract nicely. So use two instruments, use your left instrument to pull the sac medially and try to create, this is a long-standing hernia, there will be little bit of fibrosis. So pull the sac medially nicely and use little bit of electrocautery and stay on the peritoneum. Always the tip is to stay on the peritoneum so that you will not be injuring the surrounding structures. And main other point which we have to remember is we should not hold the cord structures directly with the instrument. We never hold the vas deferens or spermatic vessels directly in order to reduce trauma to these structures. So once the sac is divided circumferentially, then the next step is very easy. Give nice traction to the divided sac cranially, and then this will expose the plane. There will be, in a chronic case, there will be lot of fibrosis at this level, which we have to be very careful. In that case, you have to be very careful. So now this step is called peritalization of the cord structure. So you just reflect the peritoneum posteriorly in order to place a large size mesh. So the aim of this dissection is you are basically stripping the peritoneum away from the surrounding structures and creating a space to place a large size mesh. And here you can see the dissection of the direct inguinal hernia. You can see once you are in a proper plane, here you can appreciate that we are in a proper plane, that is the fascia transversalis, which is white in color. Put your instrument on the fascia transversalis and push it away, it will move away. And little bit of coagulation, if you see a small vessel, you apply a little bit of cautery so that there will not be any bleeding, because once it gets reduced, then it is very difficult to, you will not be seeing that area. So if there is any bleeding, there is a chance that you might miss it. So now and then cauterize the small bleeders or small vessels before completely reducing the direct sac. And after that, you have to cross the midline to the opposite side so that the mesh will come beyond the midline. If you are dealing with a direct hernia, especially a large direct hernia, the mesh has to come nicely on the medial side. It should cross to the opposite side for at least 1 to 2 centimeters. Minimum 2 centimeters crossing should be there. The fifth step is deploying and anchoring the mesh. A large, at least 15 by 12 centimeter polypropylene mesh is used. The mesh is inserted through the camera, 10 mm camera port. You have to fold it like banana leaf, what we used to use here in this area, banana leaf for food. So you have to fold it like a banana leaf, and it is inserted through the camera trocar, which is the only 10 mm port available. The mesh is placed in the appropriate position and fixed by 10 polypropylene sutures. Some centers they use tackers or glues to fix the mesh. Anything is okay. And the first suture is placed at the level of the Cooper's ligament. The second stitch is at the undersurface of the rectus muscle, and the third stitch is to the conjoint muscles lateral to the inferior epigastric vessels. And the mesh should not be sutured or stapled at the level of dangerous triangles and inferior epigastric vessels. You can see during the preparation of the mesh, normally we don't touch the mesh at all. The sister, she changes her glove and she prepares the mesh, she folds the mesh, she gives the mesh to the surgeon. The surgeon is holding the mesh with needle holder alone. We are not going to touch the mesh. So only with the needle holder we hold the mesh, and after removing the washer, we will introduce into the peritoneal cavity. So that should be followed. So change the glove, prepare the mesh, fold it and give it to the surgeon. Surgeon holds the mesh with the needle driver to take the mesh inside. So that is how we have to take the mesh inside, and you can see how the mesh is lying inside after the placement. And this is how we have to place the mesh. There should not be any undue fold, and the dissection area should be larger than the size of the mesh. Never try to reduce the size of the mesh. Always the dissection area should be few millimeters larger than the size of the mesh on all the four sides. The mesh should cover the myopectineal orifice. When the mesh is smoothed out, it overlaps the pubic bone, crosses the midline, and there should not be any wrinkles or folds in the mesh. And the first stitch you can appreciate, this is at the Cooper's ligament. During this stitch, you have to make sure that you are not injuring the vessel which is crossing. That is the corona mortis. That is the anatomical variation, which is the communicating vessel between the inferior epigastric or external iliac vessel to the obturator vessel. So if the carbon dioxide pressure is more, there is a chance that you will be missing the veins which is crossing the Cooper's ligament. If there is any doubt, reduce the pressure and see. And the first stitch is at the Cooper's ligament. The second stitch is placed at the undersurface of the rectus muscle, and the third stitch is to the conjoint muscle. This is 3-point fixation of the mesh, and you can appreciate this is how we normally place the mesh. So this is, you can see a bilateral direct hernia. You can see mesh is placed, which is covering the myopectineal orifice, and we have made a stitch to the Cooper's ligament, and we make sure that there is no folding of the mesh below before actually leaving that area. And the second mesh is, sometimes if you are using two meshes, for bilateral hernia, if you are using two meshes, you can finish the first mesh, you can fix it, then you can come back to the second mesh. So the mesh is spread nicely, and the second mesh is also fixed to the Cooper's ligament, and both the mesh together, two meshes are there overlapping each other, and these can be fixed to the undersurface of the rectus muscle. So you can appreciate this is a macroporous mesh, nicely laid out mesh, and there is no folding, and there is adequate overlap, especially in a direct hernia. And below also you have to make sure, mainly at the level of triangle of doom, if there is inadequate dissection, you have to extend your dissection to accommodate a large size mesh, and there should be more dissection area than the size of the mesh. That is how we have to place a mesh. Sixth step is peritoneal closure. A thorough closure of peritoneum and any rent in the peritoneum needs to be done thoroughly. The peritoneum is closed by running sutures, 20 PDS or 20 Vicryl. Look and make sure that the mesh is not exposed to the bowel, because if the mesh is exposed to the bowel, there is a chance that patient will come with post-operative adhesions. Actually, the trick or the tip is you have to start from the far place and you have to come near. That means In left inguinal hernia, you have to start from the lateral aspect, you have to come medially. In right inguinal hernia, you are starting on the medial aspect and you are completing at the lateral aspect. Especially in I'm talking about a right-handed surgeon. This is how we are closing the peritoneum. You can see this is the left inguinal hernia. So we are starting on the lateral aspect and then we'll be coming on towards the midline. And the peritoneal carbon dioxide intraperitoneal pressure can also be reduced from 14 millimeters of mercury to 10 or 8, even 8 millimeters of mercury if it is a thin peritoneum. And another trick is if you include a little bit of fascia transversalis during the initial part of flap creation, peritoneal flap creation, that will help to prevent the injury to the peritoneum. And another thing is rather than pulling the thread, you can take the lower flap towards the upper flap while pulling the thread. That can also help you to reduce the chances of making large holes in the peritoneum while suturing the peritoneum. So a thorough closure of the peritoneum is must. That is the main thing which will prevent a post-operative adhesions. So, and before completing the procedure, you make sure that all the suture materials and threads are removed from the peritoneal cavity, and you also make sure that you are closing the port which is 10 mm or more than 10 mm. That should be done. And you have to park the needle. Main thing is you should not miss the needle inside the peritoneal cavity. Sometimes if you miss the needle inside the peritoneal cavity, then it will be very difficult to retrieve. Make sure that you are parking the needle now and then. And at the time of retrieval of the needle also, you have to follow it with the telescope so that you will not be missing the needle. So sometimes the needle also will get stuck to the abdominal muscle or fat planes. So all these things can happen, so you should be very careful while retrieving the needle. And the camera port needs to be closed with port closure needle. Thank you very much.